All right. Welcome, everybody, to the fourth and final Legat Architects Think Tank. This is the last Think Tank session we're going to be doing here in 2021. This one will be focused on health and well-being. And to that end, we've collected a stellar panel of super accomplished people who we're looking forward to having them talk to us about healthcare, the profession, and what they do to support health equity. I am going to share my screen really quickly here. Let me go over to my Bluebeam. Share my screen. All right. As many of you know, this year we've been also supporting a competition in line with, the Think Tank's theme of homecoming. This year, the competition requested that contestants focus on the theme of the global playground, which is to create play spaces that support playful learning at every age in every community. We've received a bunch of entries, and we're so excited to have people vote on the Audience Choice Award. We have 3 different entries that have been selected to be voted on, and in the chat, I will be putting a link to view the entries in full and also to vote on them. So keep an eye out for that. And at the end of today's session, we will go ahead and reveal the results of the audience choice. I would like to welcome Legat's own Sepida Asadi from our Oak Brook studio. Seppi's been here for about a year now, and she works very hard and has put together a lot of awesome questions for us today. So Sepida, I'm going to turn this over to you. So welcome, Sepida.
Thank you, Justin, for the introduction, and hello, everyone. Welcome to the last session of Think Tank 2021. Let's start by why Think Tank. The Think Tank is an annual symposium put together by Legat architects. Each year, we invite authorities from a variety of disciplines to speak about trends related to their area of expertise, as well as how the design impacts those fields. In recent years, the symposium has featured discussions about biophilic and sustainable design, health and welfare, school safety, urban sprawl, and many other timely topics. This year, we are partnering with the Chicago Architecture Biennial and AIA Chicago. Today's conference will focus on the ways enabling architects, designers, and health advocates to recenter their focus on disadvantaged communities affected by health disparities. What is homecoming? Homecoming is the act of bringing the disinvested back to the table, with all the bittersweet realities that can entail. Reinvestment is the language of homecoming, not a physical return to a specific place, but a promise made by investors to communities and users that they matter and that they are part of a legacy that will continue long after they're gone. In terms of today's program, soon we will hear from our keynote speaker, Deborah Giesler, followed by Q&A session until almost 3 p.m., 3:05. Then we will have a quick break representing this year's competition entries. We will get back together at 3:15 to have the panel discussion. And toward the end of our program, at about 4:45 p.m., we will announce the competition winner. A note to our audience who are AIA members, you will be earning 1 AIA learning unit for attending the lecture part and 1.5 learning unit for attending the panel. Next. It's my honor to introduce our keynote speaker, Deborah Giesler. Deborah graduated from the University of Iowa with a Bachelor of Science in Psychology and from Governor's State University with a Master of Science in Communication Disorders. She began her career as a speech pathologist and brain injury team leader on the inpatient rehabilitation unit at Lutheran General Hospital. She continues as a registered speech therapist in the hospital's acute care setting. Deborah began her work as an executive director and founded Midwest Brain Injury Clubhouse in Chicago in 1998. In 2011, she founded Synapse House to address the needs of those in the suburbs of Chicago. Her passion for the international clubhouse community began to provide much needed long-term services to those with traumatic brain injury. Throughout the years, this passion remains strong, inspired by the strength and courage of the members who worked so hard to regain the skills lost and live their best life. Before we continue, here are the learning objectives for Deborah's presentation as required by AIA. If anyone has questions for Deborah, please ask them in the QA box and we will get to those at the end of the presentation. Without further ado, welcome Deborah, you have the floor.
Thank you so much. Really appreciate the opportunity to be speaking with all of you today. So my presentation today is going to be talking about the challenges, the disparities, and the hope in brain injury and stroke services. By the end of this presentation, I hope that you'll be able to understand the challenges faced by those that have acquired brain injury and stroke, be able to understand the health disparities that exist for this population, increase your knowledge of the clubhouse model, which is an internationally utilized model, and also just increase your knowledge of the person-centered philosophy that is it's currently coming out right now, and the challenges ahead in able to meet this philosophy to the very best for providers as well as for architects. So what are the challenges of acquired brain injury and stroke? First off, just what is acquired brain injury? I think when most people think about brain injury, they think about traumatic injuries. Someone had a car accident, they fell, they have a gunshot wound, something like that. But acquired brain injury is really anything that can happen during one's life to the brain. So it's a pretty vast array of diagnosis. And we see all kinds. So acquired brain injury, so I discussed what is traumatic injury, but then also some of the acquired brain injuries are those that have an infection, maybe meningitis or epilepsy, those kinds of things that can also affect their brain. So the challenges of this community are that it is a pretty complex community. And, for some individuals, there are certain characteristics that come with a certain diagnosis. For example, those individuals that have Down syndrome may have many characteristics that are very similar, which makes sometimes serving the population a little bit easier. Brain injury is not like that. It's very complex. Each person's brain is obviously different, as well as, the experiences that they have in their life. Their education, maybe, their personality, those things that they kind of brought to the table before their injury, their coping skills, who they were, the environment they were raised. So it makes it very difficult. Also, the mechanism of just having a brain injury, no two car accidents are ever the same. It could be the speed of impact. It could be if you just hit a little bit at an angle and the brain twists. It could be, your age at your time of injury. So it makes it a very difficult population to serve just because of the complexity and that no one looks the same and no brain is the same. Also, of course, the treatment that you receive at the time of your injury. Is there a trauma center close by, or are you needed to have Flight for Life bring you in? So it makes it a very complex problem from day one. It's also very much an underserved population. And I think a lot of that goes to the fact that, it is difficult to pinpoint and know. Because injuries happen throughout one's whole life, there doesn't seem to be kind of that one point where everybody can receive the information and education from the very start. People are injured from being a baby all the way until as a senior citizen. So, I have a good friend that had a child who has Down syndrome. And in the hospital, she was given a basket, and it had all of this information in it. She was immediately connected to the Down Syndrome Association in their town. There were all of these supports and things given to her, and that she was just so grateful, and it was so helpful for her to navigate. But with brain injury and stroke, that really doesn't happen. You have people coming in with a very mild injury who may leave the emergency room later that day, or someone that comes in a coma that may go to a nursing home. And it's so very difficult to really kind of provide people with the information they need and the support from that point. So that in itself, it makes things very complex. All right. So one of the challenges that we see, of course, is physical impairments. So I think it's really important to understand how brain injury affects individuals, because you can see someone who has a lot of physical impairments, and then someone who really has very little, if any. So that, again, makes it a very complex situation. So as far as physical impairments go, someone could have paralysis. They could have hemiplegia, which means that weakness or that paralysis is on one side. They could have issues with balance, coordination, sometimes movement. Their movement coordination could be very jerky, difficult, fine motor, things like that. They could have issues with swallowing. They could have issues with speech, visual deficits. Sometimes hearing is impaired. They could also have cognitive impairments. So memory and attention are actually two of the things that are most commonly affected in a type of traumatic brain injury, because those areas of the brain are most vulnerable. So a lot of times you will see people with memory deficits, attentional deficits, difficulty in problem solving, and those executive functions. Executive functions are those tasks that kind of help you pull together all the information you need and determine what the best solution is, act on that solution, and then determine if it's worked or not. And if it hasn't, how do you change it up to get what you need? And those are those very, very high levels situations that we do on a day-to-day basis that really require a lot of the brain to be functioning all in unison. So the next slide, some of the challenges also are language and speech impairments. We have some individuals who have difficulty just being able to control the motor part of their speech. Their speech is slurred. They may have aphasia where they cannot come up with the words, or they may have difficulty understanding what is said to them. They could have voice issues where they simply cannot even produce the sound. Dysarthria is the weakness and the ability to speak clearly or perhaps loudly. Behavioral impairments is that emotional regulation, organic depression, just even from the damage to the brain, not being able to release the the transmitters and all of that. Initiation, knowing what you need to do, but not being able to initiate that. Impulse control, again, a frontal lobe kind of function where you may not always show the best judgment because you kind of rush into things. So the picture of the individual, I just wanted to share some of our stories with you too while I'm talking about brain injury. This gentleman is in his 80s. He had a stroke. And as he's retired, but he would like to go around, and he volunteers with preschool and kindergarten and sings old Western songs. And one of Ranger Jim's goals with us was to be able to sing clearly again, and also to be able to play his guitar. So every Monday, he would practice a new song and, of course, play some good old ones. That's one way that, his stroke affected him, that really mattered to him. So, and it was great to see he was really able to make a lot of progress. So, okay, next slide. So some of the secondary consequences of an acquired brain injury, many individuals who have more a moderate or severe injury can lose their job, or they have a change in employment. maybe no longer able to work full-time, but have to reduce to part-time if they're able to work at all. There's earning limitations then, because sometimes with disability, they are unable to make over a certain level of income. There also is accommodations that need to be made. Instead of being able to work an 8 or 10-hour day, maybe now they can only do 3 or 4 hours. Maybe now they need special computer equipment, or they need to have some sort of accommodation on the job. The financial loss is pretty significant for those that have any type of moderate or severe injury. So just those changes in employment, not being able to work at a job that they had within their career, maybe having to take a different type of job. Also, medical and healthcare expenses can be significant. Many, many days in an ICU, or having to go to a long-term care facility. The caregivers have their loss of jobs. So now maybe you have a family that had an income of 2, now they have just 1 income, or maybe not. Maybe that caregiver then has to stop working to be able to care for their loved one at home. There's a lot of changes in relationships too. People become isolated. Initially, family and friends and coworkers are very supportive, coming to the hospital, supporting people. But then after that, as people are not as able to engage in their regular job or their regular life, they become isolated. Sometimes people have a difficult time just knowing how to kind of engage, or it makes them uncomfortable or sad. And so the people become isolated. The role of parenting, a lot of times the folks that we have currently right now, many of them do have young children. And they're having a difficult time just parenting. I have one individual who had a pretty significant stroke, and how could he run out and catch his 3-year-old, out in the community when he could, barely get around with a cane and only had use of 1 arm. The role with the significant other is something else that is very frequently changed. Sometimes the spouse will feel like they're actually a parent and not like a partner anymore. Divorce, unfortunately, is something that does happen. So those changes in relationships occur. Changes in housing. So some people are no longer able to afford a house or the area where they had wanted to live. Sometimes we've had families actually move from another state to get to resources, whether those are rehabilitative resources here in our community. We're very fortunate in Chicago to have a wide range of amazing hospital systems and rehabilitation facilities here. And we will see that people come here from other states so that they can be close to those services. Accessibility, that is a huge thing. A lot of our people are unable to drive again. So being able to get into a location that is accessible for them to get to where they need to go via paratransit or even walk. Sometimes people need supervision. So if you are living alone and had your brain injury, you may need to sell your house and go into assisted living or a type of like senior center. So access to transportation. This is huge for us, and this is something that continuously comes up. Many of our people cannot drive, or at least not initially. They have difficulty just taking public transport. If you're moving kind of slow and you're walking with a cane and people are rushing to get on a train or a bus, it's very difficult to do that. There are limitations with our paratransit system. Because Chicago is such a large area, a lot of times the paratransit systems don't cross into different counties, or if you're in the city of Chicago, you cannot go into the suburbs. You'll go into like a there's a transfer center, which is usually like a train station, and then you'll need to take another paratransit van to get to where you're going. And that sometimes is not feasible for individuals who are at high fall risk, may have seizures, or who could just wander away if they get confused or forget, which van they're getting on and things like that. So transportation is one of probably our biggest issues. Loss and access to the community. school and coworkers, recreational activities, volunteering. These are all things that, help people, kind of cope with life and be engaged. But when you have a brain injury, it's difficult to go back to school again. You lose that access to your coworkers. Recreational activities can be perhaps too expensive, or unable to play. Maybe you were someone that was really into basketball and you're unable to do those kinds of things again. Volunteering, everyone kind of needs to be needed and have a reason to get up. So sometimes having access to volunteering. So Synapse House, we are a nonprofit organization located in Elmhurst. Our mission is to empower and engage and employ individuals affected by brain injury and stroke. We serve adults from all over the place. City of Chicago, we have Boone County, Cook, DuPage, Lake, LaSalle, Will, and Kane counties. It just kind of shows you the limited amount of resources that are out there. So if people are finding a way to get to us, they're coming. We offer 4 main programs. The Clubhouse Day program is based on that Clubhouse model. And that has several components to it. And this is kind of based on an international model. Wellness, which is exercise, coping, arts. We have some virtual services still. During the pandemic, we were completely virtual for a short time, but we've maintained still having exercise in a virtual capacity. We do community integration outings. Those just started in a couple months ago, so we were happy to get those going again. We went out to a horse shelter and we're able to groom and hang out with the horses. And then next week, we're going out and assisting with one of the veterans organizations, helping stuff stockings for those serving overseas right now. So we're excited to be out into the community again. We have a community support service program for veterans where we actually go into their home and help them re-engage with their family, household tasks, as well as go out into the community. We might take them out to go shopping or to do errands, go grocery shopping, things like that, take their children out, and then also maybe go back to school again. I worked with a young Marine who had done amazing progress, and we were able to get her into a university program part-time, and then also have her first apartment in 5 years following her injury. She was able to move out of her parents' house, and that was a huge hurdle for her. So the veterans is certainly something that I have, a huge love for working with them, and I'm always so motivated by how hard they try. So we have an employment program. So we assist individuals in returning back to work. We get them work ready through doing actual work here in the clubhouse. And then we will assist with job placement and make sure that they can retain that job, working with the employer, as well as putting in some accommodations. Our family support group program, right now, we are not really meeting out in the community yet as we used to, but we do a virtual book club. All right, so I'm going to talk a little bit about the Clubhouse model because I think it's just cool. And it is our main model of care. This idea was formulated back in the 1940s, in 1943, actually in New York City, and it is still there today. It's called Fountain House. It was started initially by individuals that had some type of mental illness, because at that time people were placed in institutions for their care, but they knew they wanted something out in the community that would help support them, whether it was getting a job or just that social kind of support, finding housing. So clubhouses have a very strict kind of set of standards that we all follow if you're called a clubhouse. And clubhouses are for the members, by the members. We don't say clients or patients. Everyone is a member, and the staff and the members work side by side to actually do the work of the clubhouse, the nonprofit. The belief is work is healing for individuals. And I think what's so cool about this model is that it is mutually beneficial. So it assists the person in some therapeutic needs, and also they just feel self-esteem again and self-worth. They're being productive, they're doing meaningful work that aids in forming, relationships with others, but it also aids in the organization. So the more that they can do, the more the nonprofit is able to do, and then we can serve more people. So it's a very cool model of care. Financially, on average, though, it generates only 70% of its revenue needed. So it is, the philosophy of it is amazing, but the day-to-day can sometimes be a challenge on being able to run this type of clubhouse program. So we have many accreditations. We are CARF accredited, and that is the Commission on Accreditation of Rehabilitation Facilities. We are required to have an accessibility plan, a strategic plan, a cultural diversity plan, a risk management plan, financial plan, and a workforce development plan. So we very frequently look at accessibility, and I'm going to talk a little bit more about that because I think that's an area that architects and individuals looking at planning can really help us out. We have a brain injury waiver. That is Medicaid and funding that assists people in their home and community, and that requires our CARF accreditation. We are hoping to be accredited through the developmental disability waiver. For us, that would be serving individuals who sustain their brain injury under the age of 21. We would also like to get our adult daycare certification. That is both related to waiver funding and then also through the Department of Aging. And then we are also, we are approved to provide community support services through neuro community care. And those are those services for our veterans. This photo is Tony. He was actually in the Air Force, and his helicopter was shot down in Afghanistan. He, of the 5 on there, 2 survived. He sustained a pretty severe brain injury, but he's so motivated and he's super artsy. He's planned a lot of things, to work with his children and be engaged with them and his wife. So a lot of the things we do with him are planning activities that he can engage with in his family and just be a dad again. So what are the challenges for Synapse House? How do we serve more individuals in need when Chicago is such a vast area and people are so different and not everyone is able to qualify for all the different types of funding? Space, we are a small nonprofit that doesn't have much funding. We need to meet all these different types of accreditation regulations. Clubhouses are purposely understaffed, and that is so that the members are productive as well. So everybody is part of the team. That's a little difficult on the staff sometimes and able to get things done efficiently, but it's really all about the process. So financially, brain injury is not well funded. There's not a lot of grants out there for it typically. So we really kind of struggle for that. Ongoing effects of the pandemic, like so many others, we see decrease in donations. A lot of times restaurants would donate to us for auction items, and also just our members not coming in as frequently, because of their healthcare concerns. So we have, difficulty too, just accessing experts. We can't pay to have, an accountant or things like that on our board or on our staff. So we seek out volunteers or people to sit on our board of directors. So we're always in need of something, and there's always a need. That's the thing. We're never serving all the individuals who need us. So next slide. Our vision. So our vision for 2022 is we need to have expanded space, new space. So we were very small when we got this space in 2014. As you can see, this space is our dining room, our gym, our clubhouse business unit. This is everything right here in one space. It's and this is not even all the people that attend. Some days we have 14 to 20 people here. So here they're doing their exercise. So we would love to actually have a gym that could be adapted for our members. We'd love to have a patio space to be outside that's accessible to everyone. Quiet room is something that's essential. Sometimes people can get overwhelmed by all the stimulus and having to take so much extra effort to process things, so they need a quiet space. We're trying to figure out if we're going to lease versus purchase, and location. That is absolutely huge in being able to serve all the different people that come to us and figuring out how we can serve more. We don't feel that we serve those most in need economically, and we're really trying to figure out how we can serve that better, as well as individuals who are injured under 21. More and more people are coming to us because when they turn 23 in the school system, they can no longer have that resource. So what then? Where do they go then? So next slide. So the disparities, I'm going to just point out something just even within diagnosis groups. The brain injury Medicaid waiver pays $43.25 per day, nothing for transportation, no authorization for virtual services during the shelter in place. Within the state of Illinois, the developmental disability waiver paid $15 per hour, 58 cents per mile, had authorized virtual services. And then adult daycare also paid around $15 per hour, and there was $11.29 per ride. So this is just within the state of Illinois. There was just disparity even amongst brain injury, this diagnosis group. We're paid about $6 or $7 per hour to take care of people who may have some pretty significant needs. So actually there is a change coming right now where brain injury is actually getting more equality in the services and the reimbursement. So we're excited by that. So the healthcare transformation proposal, this was presented by the Healthcare and Family Services. Again, to talk about these social determinants: economic stability, education, housing, transportation, food security, social support networks, and environmental quality. I was really excited that there is kind of this emphasis on this. I have always worked with brain injury, and it has always really had this disparity where we don't get the types of services, and it's always been very discouraging. So I'm happy that this is kind of coming to the forefront. Next slide, please. So talking about social determinants, in this study, this was 50% of health can be actually attributed to social determinants of health, which in that broad term includes social, economic, environmental factors. This is summed up, and sometimes it's just a matter of one zip code. And so this is something that we really are trying to figure out how we can best serve people with our limited resources and get to those people that really truly need us the most. So it's a picture of Jarek, and I'm going to talk a little bit about Jarek later on. In his sloth Christmas shirt, but he is an amazing individual. So we try to have a little bit of fun in our program. Next slide, please. All right, so this healthcare transformation is really looking at person-centered, integrated, equitable care. I'm so excited that, the changes that are coming in healthcare are allowing the brain injury population to have some of the same resources that developmental disability and some of the other groups are getting. So working with this Medicaid work group, legislators are really looking at real, sustainable, equitable, customer-focused change, outcome-based measures to reduce these disparities, and then transformation funds just not going towards a status quo. I think those individuals that have their advocacy a little bit more organized and together, or larger numbers, have done better, certainly than our individuals that have brain injury, and then this new young stroke population that's really increased significantly. This is a picture of Kevin. He is one of our veterans who sustained a gunshot wound. We take him to his personal trainer, as well as our staff works with him and does a lot of exercise with him, helps him do a lot of needed repairs in his house. And sometimes they just go out and have lunch and enjoy the day. So next slide, please. So home and community-based services, day programs, personal assistance, adult daycare, those are some of the things in the program that we're in. Next slide. What is why home-based services? Usually they're more cost-effective than having someone go into a nursing home. To be more cultural responsive, it is to be more individualized services that's offered in their particular home and community. Just the person also enjoys being in their own home or being in the community that they know. And then some of the waivers do permit family members to be paid as caregivers, which is really significant for those that are not able to return back to their job. Next slide, please. Challenges, obviously, access to providers, qualified caregivers. Brain injury is a difficult population sometimes to work with. Just, non-family caregivers may have, currently, of course, right now, there's a difficult time in just getting employees in general. So sometimes people want care, but they don't want their family members to provide it as their caregivers. Everybody kind of needs a break from each other too. So, it's a difficult situation. So next slide. Okay, so the final rule of the Medicaid funds to provide home and community-based services has really kind of changed. So they want to enhance the quality of the programs, add protections for individuals receiving services, and make sure everybody has full access to the benefits of being in the community in the most integrated setting. This seems pretty obvious to all of us, but the logistics of doing this can be difficult. I am very excited, though, that this is happening because, again, I think this is what we need in the brain injury world to give us more equitable services to other disability groups. So next slide, please. All right, so this person-centered planning process really wants individuals, to have choice and being able to, be integrated into the community as best possible. We have always had individual service plans for our members, what their particular goals are, what their preferences are. But it is sometimes difficult when you have limited staff and limited funding to be able to address those fully in a community setting. Here in our facility, we can do a lot more of that, but individually taking people out, this is going to be a little bit difficult for us. So next slide, please. All right, so achieving these outcomes, again, this is what we have done and worked with our people, but again, they're really focusing on that integrated community setting, which is not the facility, but being out in the community. So we have, people come in and do art classes and things like that. But what they're really looking for is how would we take our members out into the community to attend an art class in the community? That's something certainly we would always love to do, but the reality of that can be challenging. For safety purposes, we always have one staff person for 3 members. Because we do have people that would easily get lost, people that could fall, people that have seizures. And so in theory, we are really trying hard to integrate our folks into the community, but this is going to be a little bit of a challenge for us. And I think this is something that people kind of have to think about, when they're creating buildings and space and the community and how it's set up. So ensuring the delivery of services in a manner that reflects personal preferences and choices. But again, that's what we've done, but how can we really truly integrate into the community and make sure that it is accessible? So that's kind of what I'm hoping you can help with. Next slide. Benefits of our care and this person-centered care is it is individualized, always with people's own input, reduces institutionalization. There are no more sheltered workshops, nor can people work for anything less than minimum wage. And then the clubhouse model, of course, we support this philosophy, quality of life. We want to make sure that our people are living their best life. And inclusion, and this is not just for the person, but really their family too. How can we make sure that they are included and well into the community and not isolated with their family members. So challenges. This is really where I kind of appeal to you on how we can best, have accessible services. Environment, our individuals have a lot of difficulty sometimes with noise. There are trip hazards, safety concerns. They may have reduced vision, double vision, issues with light sensitivity. So coming into an environment, how do we make that as simple and accessible yet pleasing? Accessibility, easy entryways, bathrooms that are truly large enough. I think sometimes people say, oh, it's handicap accessible, but if you've ever had to take somebody into a bathroom in a wheelchair, you'll learn that that's not always true. Our bathrooms are not fully accessible either. It depends on the person and the size of their chair. So we actually have that fancy curtain hanging up sometimes if we have to get a couple staff people in there to assist with the transfer. We are not able to expand our bathroom size just because of where they're located in our facility. So I think the reality of being accessible, I think, you really have to take somebody out in the community, whether it's with a walker on a slippery sidewalk or a wheelchair. We have a couple of big guys here, and it's different, pushing around somebody who's 120 pounds versus 200 pounds and, 6 feet something. So supervision and assistance. When we take people out, we need to have safe care. If someone needs to use a restroom, how can we make sure that we're still keeping an eye on the couple other people that we have with us? And just the reimbursement for that too. It's hard. It's hard to have enough staff to make sure that we really provide a great experience out in the community and provide safety. Equal access, we do have limited funds to participate. Our members do. And then just fatigue and transportation and equipment, grabbing walkers and wheelchairs and all of those things that we can go out in the community and really be fully included. Next slide. So this current care delivery model, it has a healthcare system and then a community system. So again, how do we really make those two things kind of flow back and forth? We are part of a continuum of care. And as healthcare stays get shorter and shorter, people get less rehabilitation. They're coming to us faster and faster with a lot more impairment. And I like that we're part of that continuum of care. I feel that we provide a role there, and a very important role. And I like to see that the hospitals and rehabilitation centers are seeing us as a way that we can be part of this whole community and work together. So, but I know there's a lot of disparities in all hospital systems or healthcare systems being able to really link up as best they can with the community providers. So I hope that's something that will continue to improve. So my challenge to you all is to help us really have equitable access to all activities in all areas, that it's practical and affordable, that you consider the needs of persons with disabilities just beyond those physical needs, but thinking about people who have visual deficits, who have mental fatigue, who get easily disoriented, who have memory deficits, difficulty paying attention in very distracting environments. Consider the needs of caregivers and those care providers too. Being able to, have a restroom that's accessible if somebody needs to go in there. Transportation limitations, we would love to go all over, but there are a lot of limitations between county and village and cities. So that makes things very difficult to us. Reverse integration. This is a pretty cool concept of where individuals who have no impairments come in and maybe perhaps they're all doing wheelchair basketball, but only some people actually use a wheelchair, but they're all playing on that same field again. We want things to be desirable when we go out. A lot of our people are very proud. They don't want to be seen as disabled, but they just want to fit in. So having those activities and that access be look desirable, and that it's sustainable. that we're able to have a space that we could easily get in and out of if we want to go out to eat or we want to partake in some sort of activity, that, we can really access those things as easily as possible. So Hope, I just want to let you know that, these are individuals who have a lot of hope, and we really are imagining the possibilities, and, we're excited. We're looking to the future. This is Jarek. Jarek sits on our board of directors. He's one of our members. He has an amazing story. He went into heart failure in his 30s. Ended up being in a coma, had organ failure of all types, and then ended up having a stroke. For a couple years, he actually lived with a device that kept his heart going. And one day during our exercise class, he received a call from his mom stating that she was picking him up, and he kept saying, "Right now?" And she said, "Yes, right now." And he said, "Right now, right now." And then he said, "I've got a heart." And so he is really an inspiration to us. He's really a kind individual who reaches out to all of our members, and we want to make the very best life for him. His next goal is to get a job. And so, we're really happy to be on this journey with everyone. And we hope you'll get involved with us and make the community as accessible as possible so our folks can have the best quality of life. So I want to thank you so much for your time.
Thank you, Deborah, for such an inspiring and eye-opening presentation. So we have almost 6 questions for you here in our QA box. The first one is asking, would you please share with us if you have any experience with people in correctional or detention facilities who suffer from TBI, traumatic brain injury? This group may not have been screened for TBI and may not be getting related care. Is there a community plan for the group to reduce the challenges that may continue after a person is released from the facility?
That's a wonderful question. I do not know of any program that identifies individuals while they are still in the correctional facility. We do screen people. We ask if they do have a criminal history when they come to us, because that certainly can affect some of their employment options. That's a wonderful question.
Yeah, I'm really curious, to see if even there is a trend out there, right? Are people caring about this group or not? Mm-hmm. Something to think about, definitely. The next question is asking, what kind of design features beside ADA and space programs should be built into the housing, public or private, for people with moderate to severe brain injury? Any advice on interior design and acoustic requirements?
I think, I think the idea that this space is appealing and that it looks like a home, our members are still part of their family, and being able to engage, with their children. Also just, I think, sometimes you have to just take people out and try things out and see how it is to maneuver a wheelchair around, whether you're, actually getting into the wheelchair or you're pushing someone, having people. I actually would go to the experts, the people that need to use the services, and try things out. Can they transfer easily into that shower that's designed? I know there's a lot of aging in place requirements and certifications and things like that, which are amazing. And many of those would really assist our people. I think also just to keep in mind the needs of those caregivers too. There's always somebody there taking care of them if they have a severe injury. As far as interior design, some of that may need to be person by person, keeping pathways clear. They may need to have, an area where sometimes we use like memory lists. So like on the way out the door where you always have your keys, there's a list of things to make sure that you have to aid those people, or maybe in the bathroom, all the things that you need to do to get ready for the day. Consistency, always having the same place really aids our people with brain injury. So that they're routinely doing something the same each and every time, even though they have memory deficits, that repetition and muscle memory. So maybe designing space where there is always a set place that's very clear for, this is where all the menus go, and this is where the grocery list goes, and these are where the keys go, and this is where everything plugs in. Those might be some things to make things very practical, not just for, individuals with brain injury, but probably all of us.
For the caregiver too, right? And,
yes.
Because the question was addressing the acoustical requirements too, do you have any experience with these guys, being sensitive to sound and noise, something to be aware of, as designers, so we can design adequately for them?
Yes, I did work with one woman who frequently had earplugs or some type of device, because the noise to her was just literally painful. And despite, a lot of different therapy techniques, it was very difficult for her to function sometimes. And she would have pretty significant headaches. And it just really took her, she was cognitively able to do quite a bit, but because the noise would be such a drain on her, she would need to take frequent breaks. So I think having kind of that quiet space where the lights are more soothing, where people can just kind of take a moment to reduce all the levels of stimulation.
Yeah, all right. The next question. Thanks for your informative presentation. It seems this group of people is always overlooked and are not part of the most of the conversation around health disparities. Do you think this topic should be addressed in our educational system from early ages to enhance the sympathy and care?
I think most certainly. I know what is kind of coming out now with CMS, and this healthcare transformation is kind of getting around or getting away from having a label or a diagnosis and really looking at more people's needs and making that more equitable. I do think, just tolerance and empathy, and how it is to function with certain things. I think early on, of course, children tend to be more accepting and just, kind of, I guess, creating those opportunities where people are included. I know one thing I always talk to my daughter about is just people being different, and, those differences, make life more interesting. Otherwise things would be boring, and who wants to be boring? But everybody can, bring something to the table and have something that they're, I always want her to just be aware. And I think exposing children to different types of disabilities very early on, like she likes to come here, and sometimes one day she came and made a birthday cake with one of our members. So I think, that tolerance and exposure. But I think in the educational system too, because brain injury is so diverse, that families may need, I guess, a little bit more assistance with resources outside the school as they transition.
Right. Good question. The next one. My grandfather has started to suffer from dementia. Providing a comfort zone for family to better help their loved one is important, but every culture has different definition of care. How do you plan for these different needs? Are you studying and predicting these culturally diverse needs, or would you provide them by experience and if needed?
So this is something that we do not have a very diverse population here. And I know that's something that we really want to do. We tend to look at individually what are people's needs, and really I think it's about listening to individuals on what they need and getting to know those families. Everybody has a different situation and come to us through different life experiences. So really individualized care. is something that we really strive to do, and just be good listeners. I think, we talk about culture, but interestingly, at my first nonprofit, we had members, we had one individual from one of the wealthiest suburbs in Chicago to individuals who are living in public housing, which we would provide food for. So this really disparity, this economical complete difference, but we never had any issues within the facility because they were all really bound together by the fact that they all suffered an injury, a very common kind of injury, and they were more focused on working through that and saw each other as equal peers. And that was something that was really, really cool about the clubhouse model, that we didn't see, some of those kind of disparities. So.
Yeah, exactly. I mean, you would never feel the need or, understand these group of people until you experience it, right? So it's not something that you can prep for it until it happens to you. It's the same story because my grandfather started to suffer from dementia too. So I get that. The next question, can you please share with us some of the challenges you encountered firsthand with patients adapting to a new space? How can we design-wise ease the transition? How can we make it smooth?
So this is something that we do quite frequently, have some challenges here because we have this tiny space and we're always trying to add more programming, and we added employment, and we're trying to add more exercise. So we unfortunately have had to rearrange things. And today we even got called out on it because the OT had set up a special desk so she could work more on standing with this one individual. So I think design-wise, our folks really do best with routine and making it obvious that everything this goes here and this goes here. And we're going to follow kind of the same things each and every time, the same way that we do things. It's the same entrance, it's the same exit, it's the same place you put your coat. I think that makes things less difficult for people, and that they're also more independent then.
Right. The next question is kind of the same. Have you come across any environmental design solutions that you've liked? If so, can you share your favorite environmental feature?
We have not, and I would be so interested to learn more about some of the solutions that are out there as we seek new space. We took this as a brand new startup, this space, and while we're thrilled with the kitchen, it was actually a pizza restaurant before we got to it, so we love our kitchen. But I think for other things, it hasn't worked as well for us. And it's just really been a monetary kind of hurdle and a space issue. So I would love to try out some new environmental designs. And our folks love to give their opinions on things. They love to be part of research. And yeah, that would be great. I would love to do more of that.
I hope our designers and researchers, they are listening carefully.
Yes, please. Anyone has an hour, I'll take it. Or a random thought, you can email me anything.
No, totally. That's why we're here, right? To learn the needs. Final question. Please share your story. What was your path to Synapse House?
So my path to doing this is, I was a brain injury therapist on the brain injury team. And, we had this amazing team and we would see some of the worst cases come through the hospital of all ages. And the one thing that kept coming back to me, people would come back and say, okay, I did this. I got out of the hospital. I went to the rehabilitation program, but what now? What am I going to do now? And the families would also kind of look at us and go, what now? We don't have the training to do this. What are we going to do? So I think, it was so important for us. We worked so hard to get people where they were at and really, how could we best make their lives? We really get attached to people, of course, when you're working with people in such an intimate setting, when you're feeding them their very first meal after they've been in a coma, when you're watching them take their first steps or speak their first word. We really felt that we wanted to help people above and beyond just that hospital stay. So one of our neuropsychologists had gone to this conference and heard Dr. Harvey Jacobs talk about the clubhouse model being used in the brain injury community as kind of a pilot. And she said, we should do this. And of course, we had no idea what we're doing as far as a nonprofit, but it was really very grassroots. It was our brain injury team. It was some families, some doctors. And we just decided, we wanted to do this for our patients. So it's such a fulfilling thing, though, as a therapist, to be able to really watch people and get to know them again. When, in the hospital, it's such a short stay now that you really don't get that opportunity anymore. So,
right. One more question just dropped here. Ideally, where would your new facility be located? Do you have ideal partners, universities, or healthcare facilities?
Yes, so I think we are currently in Elmhurst. We don't want to go far from here. We're really trying to maximize as many people as we can serve. And there are a lot of expressways that kind of come together around this area. I would like to have more access to individuals who need us a little bit more. There are these transfer points. So I think our facility being closer to a transfer point would be good, so that we could serve more people in the city of Chicago or other counties who could take paratransit to that transfer point, and then we could get them at the transfer point versus them actually transferring. We have some rehabilitation facilities that refer to us frequently. It would be nice to also be close to them so that we can kind of provide, we are part of their continuum of care. So it would be good to be physically close to them, not certainly on their campus or anything, but be closer, I think. So I certainly don't, Chicago's so large that if someone just donated endless money, I think we would easily have 3 or 4 satellites where we could best serve people in so many different areas. I think transportation and just the physical distance is what keeps people from really seeking the services. It's hard, especially when there's snow and the time to get, traffic and all of that. So transportation, it's just really, it's such a hurdle for us. So
yeah, good discussion. We are about at the end of our conversation for the keynote part. Thank you, Deborah. Thank you so much. It was amazing. Everybody, please take a break, grab a snack, drink, get back at about 3:15. And, we will have the competition images that you guys can just watch and vote, please. Go online to the website that Justin dropped to the chat box and vote for your favorite. Thank you.
Yeah, guys. So there is a link in the chat. You can view the 3 entries, and you can also vote for your favorite one. So I've seen a couple of votes roll through already. So keep looking at them, keep voting, read the narratives, hear from the teams, and then at the end we'll announce the winner of the Audience Choice Award. So thank you, Deborah, again. Thank you, Sapita. We'll be back in 10 minutes.
All right. Welcome back to Think Tank 2021, Health and Wellbeing Design. Up next, we have the panel discussion, worth 1.5 AIA learning units for AIA members. Justin, do you want to share the screen? We can't hear you, you're mute.
Yes, sorry about that. Let me get everybody up here. Really quickly, Rose, I've also made you a co-host. Welcome. So you should be able to share your video too as well. I'm going to share my screen really quickly while Seppi does the introductions. All right. There we go.
Perfect. So in addition to Deborah, which is going to join our panelist team, we have 5 other great professionals with us today, which I'm going to introduce you now. Starting with Dr. Paola Portela, Chief Medical Officer and Pediatrician at Angel Harvey Family Health Center in Chicago. Dr. Portela is a board certified pediatrician and a fellow of the American Academy of Pediatrics. She graduated from Northwestern Illinois University in Chicago with a Bachelor of Science in Biology and a minor in Sociology. She also graduated with honors from Ross University School of Medicine and holds a Master in Healthcare Administration from National Louis University. She completed her residency in pediatrics at the University of Illinois at Chicago. Dr. Portela was born in Colombia, South America, and raised in Logan Square. She is bilingual and understands the multicultural facets of society to medicine. Her special interests are in areas of high-risk pediatric patients, newborns, obesity, nutrition, asthma, or allergy illnesses. Dr. Portela has been an enthusiastic and dedicated member of Angel Harvey Family Health Center since 2017. She exudes dedication and leads by example in her role as Chief Medical Officer. Welcome, Paola.
Thank you so much for having me.
Our honor. Dr. Rose Mabwa. Rose serves as a Chicago Region Community Life Director as a community builder, supporting several sites and working with TCB's real estate development, property management, and fund development teams. Beginning 2012, Rose worked for TCB at Oakley Square Apartments on the west side of Chicago, leading the planning and execution of programs that assist 520 residents. Prior to this, Rose worked for 12 years for a national housing nonprofit as the Director for Resident Services. At 2014, she was awarded TCB's Collaboration Award. Rose holds a doctorate in education with a concentration in organizational leadership and a certificate in psychology of management from the Chicago Business School. She got recognized as well as received a scholarship award for efforts of galvanizing the disfranchised communities on the west side of Chicago and connecting residents to resources by Spirit Business School, where she received a master's in fund development. She has several awards from HUD and the most recent one from Rush Hospital for her work in diversity and inclusion. Welcome, Rose.
Thank you.
Jenny Hahn, Director of Design Integration at Boldt Company in Chicago. With 27 years in the design and construction industry, Jenny is an accomplished licensed architect and leader in the healthcare world, with extensive experience managing design teams, coordinating lean integrated collaboration across industry stakeholders, and advocating on behalf of owner priorities. For the past 4 years, Jenny has executed DFMA, Design for Manufacturing, for modular healthcare projects, including both a sliding exam room pods and full volumetric modular healthcare expansions in Illinois and Wisconsin. Jenny is also a community leader and social service advocate in Chicago. Since 2007, Jenny has served on the board of directors and as board chair for 4 terms with the Chinese Mutual Aid Association, a social service nonprofit organization that serves the multi-generational needs of immigrants and refugee families from all around the world. Since 1999, Jenny has mentored high school-aged immigrant and refugee women with the Young Women Warriors Mentorship Program, as well as youth in the DCFS foster care system. Jenny earned her Bachelor of Architecture degree from Cornell University and a Master of Arts in the Social Science from University of Chicago. Welcome, Jenny.
Happy to be here.
Sheila Cahnman, President at JumpGarden Consulting in Chicago. For over 39 years, Sheila has devoted her career as an architect to planning innovation for healthcare facilities throughout the world, with an emphasis on improving the patient, family, and staff experience. She led 3 award-winning regional and national healthcare architecture practices. In 2014, she founded JumpGarden Consulting, a women's business enterprise that specializes in healthcare facility planning and programming. Sheila has directed design and planning for over 70 medical centers worldwide. Sheila is an American Institute of Architects Fellow and a Fellow and Board Regent for the American College of Healthcare Architects. Sheila is the former president of Chicago Women in Architecture. She was named one of the top 25 most influential in healthcare design by Healthcare Design Magazine 2010. Sheila, glad to have you.
Yeah, glad to be here. Thank you.
Abigail Brueggeman, project manager at Northwestern Medicine in Chicago. Abigail graduated from Cornell University with a Bachelor of Science in Design and Environmental Analysis in the field of interior design, beginning her career at Giesler in workplace, branding, and retail design. Her focus changed to healthcare after experiencing firsthand the loss of a loved one to a hospital-acquired infection. In 2003, Abigail joined Northwestern Memorial Hospital, providing project management and in-house design to a Streeter-Weill Hospital. In 2009, Abigail transitioned to the Children's Memorial Hospital to lead the construction effort of Anne and Laurie's Children's Hospital of Chicago. In 2015, Abigail moved back to Northwestern Memorial Healthcare Corporation and began work in the newly formed healthcare system. Her focus involved furthering the early patient first branding mission and developing the design language for the new Lake Forest Hospital. Throughout her tenure in the Northwestern system, Abigail has focused on providing interiors that support patient needs and developing positive environment that further the comfort, reliability, and trust that patients need to have in their healthcare providers. Welcome, Abigail. All right, so if anyone has questions for panelists, please ask them in the QA box and we will respond to them at the end of the conversation. Before we begin, please return to the handbook or the website for learning objectives per AIA required. Let's start the conversation. So welcome all. I have to say we are so fortunate to have each one of you with us today. I want to start our panel discussion by posing 2 general questions to each one of you. The first one is about your personal mission. What is your personal mission? And how does your current role at your organization align with or fall short of this goal? We can start with Sheila, please.
Well, thank you very much. Well, very interestingly, as you mentioned, I've been doing healthcare planning for many, many years now. And the last 7 years, I started my own practice. And so I can say that my role is where I want to be because I get to decide what I want to do. And one of those things that I've been most involved with in the past couple of years is being able to choose certain clients to work with that have more of a mission and vision role. Not all my clients, but most of them. And that's included hospitals that are public hospitals, safety net hospitals, a lot of work with, as Deborah mentioned, the Veterans Administration with veterans and designing for them, which has been terrific. And as I'm going to mention in a little bit, even working with Native American design projects. So for me, all that aspect is very fulfilling.
Fantastic. Rose, can you go next?
Sure, I can go next. So my mission in life has always been to be a voice of less fortunate and to elevate the voices of the low-income housing families. And I am where I'm supposed to be because Community Builders, it's a mission-based non-for-profit organization that builds and sustains quality, affordable housing for people of all income. So I'm able to, my values and the mission values align because I'm able to not only partner with our residents, but bring resources to help them thrive at a place where they call home.
Fantastic. Abigail, we would love to hear from you.
Right. Well, thank you. My mission in life has always been centered around the power of design. And I believe that design has one of those things that few people understand, the specifics around it, but they understand the value of it and the benefit when they experience it, but they can't necessarily put their fingers on it. And so for me, the power of design has always been right where I've wanted to be, practicing design, implementing it. And the ability to do that in a healthcare environment has been the most fulfilling aspect of taking design to places where people can utilize it. When I got involved in design a few years ago, it was the first Northwestern Memorial Hospital had just opened, and the notion of replacement hospitals and the fact that healthcare institutions and buildings needed a facelift and they needed to come out of the 50s was still in its infancy. And I've been very fortunate to be able to have a lot of time spent in my professional career really pushing that mission and helping people understand. And I think in a lot of ways, my work and the work that I've done at Northwestern is pretty much synonymous. It's been a great opportunity to build a brand and to show the power of design. And I think that speaks to where I wanted to be. And I think in a lot of ways, I am right where I need to be doing this mission. I think it will be fun to branch out and do it in other ways and in other locations and for other groups. But up until this point, it's been a great journey and a really wonderful time in the healthcare design field.
Fantastic. Jenny, can you go next, please?
Sure, and I appreciate the comments on design because I believe that as licensed architects, it's our mission, it's our responsibility to protect the social welfare. So that's, I think, very applicable. Personally, for me, I always felt out of place in my design studios, getting my bachelor's thesis, because every project that I touched, I wanted to figure out some kind of social impact. And my colleagues were just making really beautiful buildings. And so I was always more focused on the mission and my personal mission. And then in my career journey, I sort of did lots of things, like did high-end residential and nightclubs and restaurants and that kind of thing. But I always, in parallel, was involved with community organizing and social welfare in a sort of more specific and sort of surgical approach. And now my journey has come full circle, not only with my last 16 years in healthcare design, but also, as we'll talk about later, the modular solution, and also how that fits into lean approach, the lean approach to delivering healthcare or design, and really respecting others and pulling in the very last planner, which is pretty much the occupants of these spaces, and bringing their voice forward into the design process.
Fantastic. We can't wait to hear more from you. Paola, please.
So my mission is really to help the underserved obtain what we would call healthy minds and healthy bodies. As you stated, I was born in South America, and my parents actually in the 70s were able to come to the United States. However, my father came illegally. And so initially we, were illegal, and we were having healthcare at the government clinic. And as I was young, I started realizing that it made a huge difference when the provider was able to speak in a language that my mother understood. And to this day, she has not learned English. It's been 40 something years. But it really made my life mission to treat the community that I grew up in and speak the language that my patients spoke, because I felt that as far as the treatment plan, patient were able to really give their opinion, ask questions, and understand why certain things were being done. And so eventually I ended up joining Angel Harvey, whose mission aligned with my own. And as a provider, I realized I was doing so much to help the community. But if I really wanted a seat at the table where the decisions were being made, I would have to move up. And so that's why I went ahead and got my master's and became the chief medical officer, because I do think that there are some ideas that could be given by my perspective, because it's different than the perspective of others that have that passion, but haven't lived in that role.
Fantastic. Deborah, do you have anything to add?
No, I'm all of you are just giving me such great ideas, and I want to talk to all of you privately. I mean, my mission, just really to summarize, is, I just, those affected with brain injury and stroke, we just really want to maximize their recovery and help them transition from being a patient to living their very best life, whatever that might look like. So
fantastic. That brings us to the second question. Health equity is defined broadly to mean that everyone has an equal shot at being as healthy as possible. What does health equity mean to you? Paola, we can start with you.
So yes, health equity to me would mean that everybody has the same opportunity to get the same care, with the same understanding, with the team being able to communicate with the patient and have them reach them where they are. Some people can't afford medicine. Some people can't afford transportation. They can't afford a doctor's visit. And very early on, I knew I did not want to work somewhere where money and not being able to pay a visit was going to prevent them from not receiving the care that they were going to have, because that's not health equity. And so to me, it just means everyone being able to participate in the same care given to other people, regardless of their income, status, gender, age.
Abigail.
Okay, so I would say that my definition of health equity contains pretty much the same constructs that Paula's definition includes. I would also throw in there as well that access to care and quality of care are two very important things. And people talk about the access to care, but they also sometimes forget about quality of care, and they don't understand even the questions that need to be asked when they are receiving care. And so part of what I think is the important piece in this whole healthcare question of equity is really about education and exposure. And if people are not educated and they don't even understand what they're going for, or why they're going for it, or why it's important, it's very hard to convince them that treatment is something that they need to seek out, or that it should be important. So I think this disparity piece comes primarily, it starts in the education piece, and it follows a person through all of their lifetime. And if you ever have a family member, you ever have somebody who is not at all familiar with the healthcare system or why healthcare is important, sometimes it doesn't matter what their socioeconomic status is or their background is, they can still have a very poor health outcome as a result of not understanding why healthcare is critical and important. And so I would throw out there that I think the education piece is another key determinant that has to be looked at in this entire equation.
Deborah, please.
I think one of the things that, in our particular situation, as far as equity of care, is just amongst the disability groups that there is equal funding. A lot of times it just comes down to those that are more organized and able to better advocate. And I think, that's certainly where our folks have a greater disadvantage. So I think having equity to all the funding that is available, and then also, access to it. That's one of our biggest hurdles, is just being able for people to access the services.
Jenny, would you mind going next?
Yeah, I think one of the things that's really exciting to me that I'm seeing more and more is that the idea, the concept of healthcare has evolved, and that we are including more than what's in a hospital setting or a clinical setting in our understanding of what impacts health outcomes. So for me, it's understanding data around violence and trauma and those kinds of environments. And, you know, as design people in the construction industry, creating environments that react to that or take that into consideration is really important. And then, of course, housing, which Rose is probably going to talk to a lot, but that is integral to how people's environments are, how much sleep they can get, how much, you know, healthy food they can have access to, and that kind of thing. And so certainly poverty is another aspect of that. So we're having more integrated conversations about the real, the things that bring people to the hospital prior to, and that's why we're talking about wellness. But the other thing is that I think what's come out of the last couple of years is a better awareness of our own personal biases and perhaps microaggressions or misunderstandings about other people and cultures, that there is a dynamic, and we're getting more data around people having different treatment and different outcomes because it's just assumed that they're not telling the truth, or their threshold for pain is different or something like that. So having those kinds of conversations have been bubbling up and have been very important more recently.
Fantastic. Sheila, we want to hear from you.
Well, I would agree with everything Jenny says. I mean, my broad definition would be that health equity is that everyone has a chance to live the same happy, healthy life. And that's not the case right now. And the healthcare systems are only treating, that's the very, very tip top of the pyramid of healthcare. I mean, everything, all the other social determinants are so much stronger, as I think Deborah had in one of her slides. So, you know, as much as a healthcare designer, I'm designing spaces to support treatment in the best possible way for the best possible experiences. I understand that that's only part of a very, very small part of what it means to lead a healthy life. And I think we've got a lot of experts that could talk about that.
And Rose.
So I would say structural violence and dramatic ratio differences in death rates and life expectancy has to increase, because when we look at our Chicago communities, there is a big gap in life expectancy. And COVID-19 really highlighted these disparities, because just basic needs of food, healthcare, we see that raising over and over. And we had to pivot and focus on healthy foods and vegetables. You know, a lot of our communities don't have fresh food and vegetables, no healthcare. So we need to focus on that and really dig in to make a big difference. And that is my definition.
Fantastic. Now I think it's a good time to move to the communities and talk about them. So how do size, geographic features, and population densities of cities, suburbs, and rural areas impact the strategies that minimize healthcare disadvantages? We can start with Deborah, please.
You know, as I mentioned before, this is such a huge issue for us because there are such differences in transportation and being able to access. I think nonprofits, you know, I know we want to do more and serve more, but there are those funding limitations, you know, having only one facility and trying to serve so many from so many different counties in the city, just really, you know, it makes it very, very difficult. We even serve, you know, an individual, a warrior not too far from DeKalb, that we send a staff person out there. So I think it's a huge issue. I mean, but it also there's so many more resources here in communities, but I think it also makes it harder to link to the community and be part of a community and know what is out there. We certainly would want to partner better with other community providers to have a better continuum of care and be able to get our folks a more comprehensive kind of plan and access resources better and know those people on a more individual basis. But because of the vast, geographical area of Chicago and it being so different, that's very, very hard to try to get us, I guess, having, one of the things we've always talked about is just having some sort of like resource center, for all types of services. There seems to be these pockets of things, but, we don't always know, maybe it's a group that serves individuals with mental health and they know these things, but how do we all as one, group of providers have access to the very same resources and knowledge of all of that so we can best serve people. Everything is very disjointed because it is so large. And I think probably smaller communities do a better job of being linked and knowing what each other can provide. So,
Rose.
So I would begin by talking about the model that we have at the community builders, and then expand that to outside, where currently we are beginning to partner with stakeholders at all of our sites, local stakeholders, residents, and other businesses to look at, for instance, the broadband funding that's about to come out, because we know that everything has moved to virtual since COVID-19. Although we're doing some things in person, which will never be 100% in person. So we know that we need to bring our residents with us to where they can use technology. And technology, when I talk about technology, I'm talking about adoption, I'm talking about use, I'm talking about availability of it. Is it affordable to our residents? Right now, technology is being used for school. Kids are using it for school. Telehealth, you need technology. Seniors have been isolated for so long, and isolation can bring about depression. And so if they have devices, they can participate with other seniors doing fitness exercises, doing cooking, and exercising with the doctor. So technology is the way to go. And yet we find a lot of disparities in our communities where there isn't towers to connect technology. And internet is not affordable. So partnering with other organizations, both in our communities and in our state, is the way to go. And holding those community meetings to find out what is most important. How do they see the use of technology and adapting to the use? Because you can have a phone, but does that mean that you know how to adapt to technology? Can you find resources? Can you look for a job? You might have a phone, but you don't have a good quality internet connection. So we have to do a lot of education with that too. COVID also highlighted that because of isolation, you can use technology just to order food. So do we have enough devices for our residents? No. And then when COVID hit, a lot of our families, it hit them, they were not prepared. So how can you, as a parent who's struggling to go to work, put food on the table and help your kids with school when you yourself don't understand how that technology works? So there are a lot of things, but we need to partner to close the gaps and really sit down and discuss plans that will be able to work for all of us.
Fantastic. Paola, do you want to talk about the role of city characteristics a little bit? Answering this question?
Did you say Paula?
Yes.
Oh, yeah. So yes, I mean, it makes a huge difference. The more that I get into the federally qualified healthcare world, I realize that Logan Square, even though it is a very urban community and primarily Spanish speaking, with the safety nets that we do with other FQHCs, I've realized that there are places close to our clinic that are basically in the middle of a food desert. And so we tell parents, and over the pandemic, I've seen children in the case of a year gain anywhere from 40 to 50 pounds. And you wonder, you know, where's the healthy food? What are you doing? And then there's nowhere to go buy fresh produce, and there isn't enough money to take a bus to Whole Foods or Mariano's. There's barely an Aldi. And so it really puts into perspective the differences when you look at a city or a small community where everyone knows each other, and you know if someone's suffering and they don't have any food. And then you go to a larger city where, you know, it doesn't take a village anymore because everyone is so closed off, and you realize that not everybody has the same resources. And so it's very hard to, well, you should never judge, but it's also very hard to form an opinion because you don't know what they're going through.
Abigail, please.
So I think the concept of geography and the population density is, and I'll speak kind of from a healthcare, you know, system perspective. I mean, we have hospitals now in various different regions around Chicago, including downtown, and each one has a different flavor. What works at one doesn't necessarily work at the other because of the local community and because of some of the nuances that are around. But what we have discovered, and I can speak particularly from Lake Forest, which is where I'm based at, we're in Lake County, which is a collar county to the north of Chicago, and Lake Forest is one of the wealthier zip codes in the state of Illinois. But just to the north of us is North Chicago, which is one of the poorest zip codes in the state of Illinois. And we have a gentleman who came on board with us a couple of years ago, and he has been working with the community partnership group, and his focus has specifically been on North Chicago and understanding the underserved capacity that North Chicago has experienced over the years, and literally things like the lifespan difference being 15 years shorter if you live in the North Chicago zip code versus the Lake Forest zip code, and really talking about just the availability of food and the food desert and the access to healthcare. And so these things are very, very real, and they hit us in ways that probably people wouldn't necessarily understand, or like if they looked at the geography of Illinois, they wouldn't necessarily see that these communities can be located so close to each other, but they could be completely different in what the residents experience from a life and an expectancy, a healthcare perspective. So I think this is very much a real problem that COVID has kind of shined a spotlight on. And I think it's going to take all of us. It's not just the healthcare providers. It's not just, you know, government. This is really a problem that is going to require a multifaceted approach and a real serious involvement of everybody involved. People who can and want to get involved in partnering. It's going to take corporations and businesses. It's going to take state and local governments. It's going to take all of us to really solve this, because this didn't just happen overnight. It's literally the fabric of how our society is set up. So we all have to engage in order to help close this gap.
Sheila, do you have anything else?
I'm going to pass that.
What about you, Jenny? Okay, we move to the next one. Many communities contain cultural differences, the result of nations of origin, racial differences, age differences, sexual orientation, and so on. So how can we, all of us, as healthcare provider or planner or manager and designer, ensure that the messaging, design, and implementation of interventions can successfully address the cultural differences within the specific communities? Sheila, can you start for us?
Okay, well, I'd love to talk about this. And Justin, if you can throw up the images that I provided. Let's see them. Yeah, there they come. That's not mine.
That's mine. That's mine.
Here in a minute. Well, yeah, here we go. And so I thought about this a little bit, and you know, one of the issues is how do we make the voices of our constituents heard, especially if the constituents are part of an underserved community. And I thought this was a really good example to share. This was a clinic that I worked on in Rapid City that's under construction right now. It was under the auspices of the Indian Health Service, but it was for multiple tribes that participate at this Sioux Sand site. And the interesting thing here was when they had started the project, it was almost dictated to the tribes what they were going to get from the government. It was on hold for many years, and then it came back, and they were basically told, you're going to get a clinic, and it's great, you're going to get X amount of dollars to do it, but this is what it's going to be. So there was a lot of tension between the government and the tribal leadership that we had to work on to try to get their voices heard in the design of the building. And if you go to the next slide, I wanted to show you just some examples of what we did to engage. And if you can imagine, we set up a big room, and it was with representatives of the Indian Health Service, representatives of the clinical staff, who were for the most part non-native, and then the native tribes, of which there were multiple sub clans or within the tribe. So it wasn't one uniform voice. And to bring them all to the table to try to bring consensus on ideas and have everyone talk to them. And this is actually pictures of the charrettes that we did. We did 2 charrettes, and on the right, you can see this is when we were developing all our guiding principles, and everyone had a sticker to put up to weigh which was the most important principle for them. And then you can see on the left, this was actually starting to look at the layout of the building and relationships of spaces and what's important. And you could see that each small team, everyone was able to talk, everyone listened. And the thing that was so exciting for me at the end of this, besides the fact that I think we've got a really good space for them, is that they said, they came back and they told us, they said, this is the first time that we've been asked to engage in a project. Any other time we've had architects or whomever come to us and say, here are your options, pick an option. We've never been actually listened to from the very beginning. And to me, that was absolutely wonderful, and the most important thing that came out of the meeting. So this was kind of the whole idea of community engagement. And then if you go to the next slide, I'm actually, this is not what I'm working on, but it's an example of something similar. Right now I'm working with Abigail's health system, Northwestern, in Bronzeville for a new clinic building, a multi-specialty clinic. And we're looking and actually having meetings right now with the community to look at the idea of embedding community space within healthcare clinics. And I don't have any images to show yet. We're very early in the process, but this was one that I found very intriguing, which was in Arizona, which shows, and this is a Smith Group project, not my project, but I think it's very intriguing because it's the whole idea of bringing community into the healthcare setting and allowing for spaces where you can do education and wellness and you know, demonstration kitchens, things like that, and really embed it and interact and hopefully talk to the community in advance and find out what their needs are, and that helps them pull them into the center, make it less you know, make it easier and more comfortable to come in and seek help, for instance. So anyhow, that's my thoughts.
Jenny, please.
So, and I appreciate that Sheila mentioned that project that I'm going to be also engaging in potentially for modular solution in the city. But I think that we've known about this idea of bringing this voice in, and some of us have done it, some of us haven't. I believe that Sheila's examples are really good examples of true engagement and respect. And so there's a how to do it that Sheila talked really well about, but there's also who are you bringing in the room, and that I think that the more that we as individuals can engage in community and be aware, particularly with the ownership, but we all bring something to these teams, and to say there are communities that that mobilize and organize around their whatever needs, and so being able to on the ready go to the right groups, you know, that you're trying to address, find the leaders, they can find the people who are engaged, who, you know, want to be represented for these kinds of projects, whatever kind of project it is. I mean, I'm very involved with the Asian American community, for example, and I could probably, you know, just speed dial whatever leader for whatever reason. So it's important to just make sure that we're connected to the communities, but also to engage, as Sheila said, them early, and to really find the true north of the project with the community's voice, and establish their conditions of satisfaction upon the completion of the project. Maybe it's not all about the spaces that are the colors or the aesthetic, but it's the how, the how it goes about, that they feel respected and they feel engaged. It's not just about checking a box in the beginning and then giving them the result at the end, but perhaps engaging them throughout the whole process.
Abigail, do you want to join the conversation? It seems like you are a group right now.
So I would just add, because I think Jenny and Sheila have really done a great job describing, you know, a best practice for including people in these conversations and in space. It's really about people understanding that you respect and you hear them and that you value their input, because ultimately the space that you're building serves them. And so this again talks about really good design principles about engaging your stakeholders and keeping those people involved in the process. So I would just add that I think these are super important points, and they kind of cut across all the different continuums that we see when we're designing space for folks. So it's good to keep those core principles at the forefront.
Paola, do you have anything else to add? What about you, Rose?
Can my slide be put up, please? Justin? Okay, so I will start by saying that at the Community Builders, we put our residents at the center for everything that we do. We create vehicles for soliciting full residents' participation from the beginning of a project to the end. So we have steering committees, advisory committees, a task force, resident subcommittees, master plan, designer charrettes, location counseling, community support services, building meetings, property management, resident information session, and monthly revitalization plans. So this is a picture of one of our sites where we house artist residents. As you know, artist residents, they need a different design of housing because they have to hang up their art or different things that they are supposed to use. So this particular site has a gallery, and the residents, it supports the residents in that the residents can bring their art and display in the gallery and sell. So every first Fridays of the month, people from around that town come out and view the gallery, and they buy the art if they like. And this is a way of integrating our residents with the larger community. So this is one design that we have come up with that seems to accommodate artists, and more of housing of that type is needed. Second slide, please. And then second slide is a building that we are working on. We'll be building, we participated in Assemble Chicago. It's, sorry. It's a 207 mixed income residential unit serving households making 75,000 and below. The bottom 2 floors are commercial space that will contribute to activate State Street, while providing space for community-based organizations throughout Chicago to meet and collaborate. It will have a neighbor hub for meeting, events, collaborating space for community-based organization to be able to come downtown and collaborate. And it will have a food hall to support local minority businesses and that are seeking to grow and expand into the Loop area, and also micro grower and produce store. The building provides efficient health living spaces for Loop moderate and lower income workforce. The building will be carbon neutral, net zero. And why is this important? This is important because the building has high level of sustainability associated with market rate and high-end projects. Opportunity at this site will support the city to really push the envelope on sustainable design in all affordable mixed income developments. Also, sustainable features will improve the lives of occupants with this affordable housing development, as well as positively impact other communities through resources taken from the neighbor hub back to the community. So connecting surrounding Chicago neighborhoods with downtown. And then reduce operational expenditure for the building. The residents who live here will benefit from reduced energy usage, and it exemplifies how developments can play a role in carbon reduction and waste management, recycling program, and 90% of waste diversion. Sustainable transportation, it's walkable downtown, jobs, schools, restaurant, entertainment, adjacent to several public transit options, and one on-site park. And it will also have on-site parking. And then on-site health clinic. This is that's operated by Rush, that will serve several of our residents. By the way, the community builders, we always have a model. We focus on 6 focus sites, that is health, youth education and leadership, asset building, workforce development, and housing stability, because we don't want our residents to become homeless after they have been housed. So having a things like community garden, demonstration kitchen, fitness, residents, and then partnering with a health institution like Rush or any hospital is very profitable to us. And that is when we sit and do charrettes with our residents, that's what they tell us they want. They want accessible health. So at all our sites, you'll find that we partner with a healthcare institution that can provide fitness and telehealth readily acceptable for the residents. Next slide. And this is how it will look when it's finished. Next slide. So this is another one of our sites where before we were invited to go to that site, there was no playground. There was nothing that made it easier for those residents to raise a child at that site. And after sitting with residents and finding out how they wanted the community to look like so that they could call it home, we came up with a design where we partnered with Kaboom. We were able to build a playground. We converted some of the units on the first floor into classrooms. We have a yoga room, we have a computer center, we have a clinic on site, we have homework help, and we have, so the way we do these things, we partner with other partners that align with our mission, and they're able to provide resources on site, because some of the communities that we are in, they're very desperate and they really don't have any resources. So we provide resources on site, and those kids are usually 1 or 2 grades behind. So homework help is a big help. Psychological trauma is really big, and it also has been highlighted through COVID. So we partner with institutions that provide counseling to have that service readily available.
Fantastic, Rose.
The last So as I talked about before, that having basic needs, which is quality, affordable, fresh vegetables and fruits, is one of the things that we're focusing on. So at one of our sites, we partnered with, we brought in a Walmart, so the residents have readily available fresh foods and vegetable. And for one of our senior sites, we have a library where they can also read and enjoy. So having amenities that can accommodate all the residents' need is really, really important. And each site is different. No site is the same because all sites have different needs. And it's just sitting down, putting residents at the center of what we're doing, listening to their needs, and then designing based on what we hear, because they're the ones who use these spaces. We can't come in and say we are experts, we're going to do this. We have to ask them what they want, and then we design based on what we hear them saying.
Great projects. Thanks for sharing them with us.
One more slide, and then it's
no worries, go ahead.
And then when we partner with organizations and when we build, we know that we are communities within a community. So when we stabilize our immediate communities, we know that it will overflow to the larger community. So this is an arts and rec center that we build in a community. It's the first rec center that has a swimming pool, has an indoor basketball, and it's really being used. And a lot of communities need amenities that they can use like this. So that's why I said stabilizing our own immediate community flows out to the larger community. And that's it.
Awesome. No, these are all great. Thanks for sharing. Our audience, they have a question for Jenny. And that makes me to ask my question first. To meet the growing needs of the community-based outpatient services, some healthcare organizations are building clinics through modular planning and prefabrication. Would you please share with us your experience with this method? And our audience is also asking, how can we make sure the design is context or user specific? And can you talk about transportation and handling of the system also?
I am happy to do that. I actually have slides, so if I can steal the screen or share them on screen. Hold on. Yep. Okay. So I just wanted to ground the group a little bit with what we mean by modular planning and prefabrication. I believe that we do this already in our industry quite a bit. I mean, anyone who's used casework or, you know, any kind of innovative materials, like we're not using lap and plaster anymore. Drywall is considered an innovative material at some point. But so there's a spectrum to when we talk about prefabrication. Some of it's just about materials. I call it low-hanging fruit, and then all the way up to a higher innovation level. But we can have people who are pre-assembling things that they would normally do on site. So we can pre-panelize the stud walls. We can put together more pieces of the plumbing and piping and put it in as like a sub-assembly. We can have actually our mechanical, electrical, plumbing and our carpenters get together in a factory and put walls together so they can stand them up on site. So all of these things contribute to this thought about prefabrication. And of course, what we think of sort of more steadily is about these modular pods or full volumetric modular Lego blocks. But so just to ground in that, there are a lot of values that this brings to owners. It's not going to go into any of them that deep, but it's speed to market. We can work on the site and the building at the same time and really squeeze down a lot of the time. The cost, quality, and predictability. We are designing things at to a greater level. So all the things that we normally experience during the construction process as RFIs and change orders, we consider them up front and we detail them out because we have an integrated team. So a lot of this really relies on the processes of sort of lean integrated project delivery. The customer expectations are predictable. Like we know that we're going to be able to give them a quality product, and this is the way that the industry is going, and that has a lot to do with workforce development and the fact that we don't have a lot of skilled labor. The baby boomers are all retiring, and people are not going into the trades. So maybe some of the residents from Rose's buildings, they, one day they could be working and flipping burgers or something like that, but then with just a little bit of training, they can start to work in a controlled environment, assembling these modular or prefabricated elements in a factory, which is always 72 degrees and sunny, and not having to worry about like long commutes and that kind of thing. But there's also these other values that we can have this new kind of labor, which actually reduces labor costs and engages our communities more readily. We have better products, we have more productivity. It's safer. I mean, I don't know if people realize this, but bringing the work to where the materials are means there's a lot less movement, and a lot of movement provides more potential for errors and like safety incidents and stuff like that. So, but anyway, so when we're talking about prefab, this is the full volumetric solution. We have a steel fabricator make all these structures, these skeletal structures, and deliver them to the fabrication site. We'll put these prefabricated panels in one station. This is just like 1 or 2 hours worth of work in one day. And then in the factory line, we have a very well thought out and a high quality modular solution, which I think everybody, there's a misconception that because it's done in a modular fashion, it's kind of like mobile homes and that kind of thing, that it's not of a lesser quality. But this is actually of a higher quality because of the controlled environment, less dust, less waste, but then just more predictability. Lines are straighter. We know what's going into the walls. Anyone who's done healthcare construction on an existing site knows that there's a zillion things that can happen within those walls that you don't know. And then when you're going to fix something, then you open up the wall like, wait, what the heck happened here? So these are very predictable because we're leveraging technology. So I think there was a question about shipping.
Exactly, shipping and handling, right.
Yes, so the modules are limited by how wide the road is and how high bridges are. This is just a fact, but we can pretty much ship anything, but it just begins to be a little bit untenable when it's too tall and you have to find routes around where there's bridges. You'd be amazed how many bridges you travel under and over. So they're handled by actually shrink wrapping them. And so they're weather tight, but they're actually also designed for the picking and setting. That's where the highest level of structural disruption happens to it. So many of these modules that are fully volumetric and support themselves and also like potentially floors above, they can go into seismic zones without an issue because it's more traumatic to them, their structure moving down the road and being lifted and such. But the next thing is not just design, context specific. Okay, so that's an interesting question to me because this is the third version of a modular product called StatMod that HDA and Boldt produced during COVID. There's a whole other conversation about that, but we were able to flex that from either an I2 occupancy or observation room occupancy or clinical occupancy. Those things are handled in design, so they can be as custom as needed, but the value in modular is the repeatability. So that's where there's a lot of potential for underserved communities or rural underserved communities where access to care is a geographic issue. There's a lot of that going on right now, in particular for neighborhood clinics, for micro hospitals, as well as ambulatory surgery centers, and all of these can be delivered in a modular fashion. They can be built in Wisconsin and shipped anywhere across the country. So really, this particular product, we slowed down a little bit in the beginning to really tailor this to the client, which is the Advocate Aurora Health System. And so they ended up with pretty much all the standards being met, and as well as the Healthy Hospitals Initiative. So environmentally and sustainably, it met their standards. And you really can't tell in the end that it's modular. There's themes everywhere inside of this, but in the end, it's just as good as a permanent building. And this is actually a photograph, if you can imagine. This, everybody says, no, that's the rendering, but I was standing right here when they were taking this picture, and I got bleeped out for some reason. But contextually, you can see that it can match the existing traditional construction without an issue. So I think the point being that going modular actually allows us to standardize our design and construction so that it doesn't matter what community it's going into. If it's going into an underserved community, great. They get the just as good quality of construction and then quality of care.
Fantastic. Speaking of technology, let's move to the technology and health system. I want to ask Paola specifically, how can advantages in health improving equipment devices, such as home health monitors and diagnostic devices and technology in general, help reduce healthcare inequalities?
I think that if people who don't have the transportation or the ability to be able to go personally into the clinic, or let's say they have high blood pressure and we're trying to diagnose it and they have to come in various times, it becomes very difficult for someone that doesn't have the means to get somewhere, or has to wait for a ride or transportation or the bus on a frigid below 0 day. And so I've started to see a lot of insurance companies or a lot of clinics lend out equipment like blood pressure cuffs or diabetes screening that links into their patient medical record. And so the patient puts it on, or they take their blood and it automatically gets sent over to us in order for us to monitor them without them physically being in the clinic. I've also seen some pop-up clinics that will have like a nurse or a medical assistant with video technology for us to listen to their lungs or look in their ears. And all of that just increases access in a place where it's either not there or the person is not able to physically go and get that medical care.
I'm wondering if anybody else has any comments on this one, the technology and healthcare.
I do. So we have begun partnering with healthcare institutions to train our resident ambassadors who are acting as liaison between the clinics and the residents who suffer from diabetes, high blood pressure, and preventable diseases, to educate them and then connect them to the clinic. So either they're connecting virtually or through calling them and then just finding out and educating them, then connecting them.
Fantastic. Let me ask this question. How can governments and healthcare providers educate and incentivize people toward less costly health maintenance, like fitness, prevention medicine, and improved diets, while shifting them away from reliance on expensive last-minute emergency room treatment? And can you talk about the role of social media and website to make this happen? Abigail, why don't we start with you?
Okay, so we have as a system started to institute through kind of our electronic medical record, we call it our primary care home base. And basically any patient that comes into our emergency room or it comes for any of our services, the providers are trained to ask the person if they have a primary care physician. And for a lot of those people, they don't even understand what a primary care physician is. And so the emergency person or the person in the emergency department then starts to work with them to give them some basic understanding of what a primary care physician is. And so we like to sign them up for the electronic medical record, which is the NMI chart, so that they have access the same way that anybody else who comes to our services has. And then they also work with those folks to establish a primary care home base. And sometimes that includes our transitional care clinics, which are basically set up as free clinics that allow people who come to the emergency room who have no safety net the access to a primary care physician. So for the high blood pressure, for the diabetes, for all these different reoccurring situations, asthma, I think is another one of the key ones, they have access to a primary care person who can then help them get on a pathway towards better health maintenance. And then with all of our patients, healthcare, I should say fitness, having access to fitness centers. A lot of our cancer care comes with automatic memberships to our healthcare, our health and fitness centers, so that folks who are going through chemotherapy have the ability to come to a fitness center. They may be able to take a yoga class. They may be able to meet with a personal trainer. They may be able to get some help with their dietary care, so that they're able to manage their disease better without necessarily having to be inside the hospital. So we have found that those things go hand in hand together, and they start to help people with training. And then the other thing that we've also done is we've implemented a series of immediate care facilities, which are not emergency rooms, but they are basically access to unscheduled care. So for folks who need they got a cut, or they sprained an ankle, or they did something that traditionally they would go to the emergency room for, instead they can go to these immediate care centers. And so part of the education process is the emergency department folks helping people who come to the emergency room understand that these immediate care centers are a great alternative for their next visit. And so we find that this, catching people as they're using the emergency room as a primary care physician is a great way to begin that process, but it has to then extend through, access to the medical chart, and also it helps educate people so that as family members learn these pathways to different care, they can then educate their own. So it speaks a little bit to the healthcare literacy piece as well.
Thank you, Abigail. Paola and Deborah, I'm sure you guys have something to say about it.
So I've seen a lot of the insurance incentivizing preventative maintenance, things like colonoscopies and mammograms, where they will actually financially incentivize somebody to come in based on their insurance, and this could be Medicaid. And if they get their things done, so if they come in for a woman will come in for her annual and get a pap smear and a breast exam done and be scheduled for a mammogram, they will actually send them money. And so a lot of people will come in and have us sign off on their little paper, because I don't really, in their head, it's $100, which is great. And I don't think they really understand the importance behind it, that if we're able to catch something early, it would be so wonderful, because it's more like I'm getting $100 for being here. But at the end of the day, I'm happy, because if they get it done, then they get it done. When we became a federally qualified health center lookalike, I actually underwent the process. And one of the things that they did that benefits us, so our reimbursement rate is a little higher than just a community health center, but by the same token, we had to prove that we had the beginning of a patient-centered medical home. And so we have anywhere from birth to end of life services. We have behavioral health, we have dentistry, and we also have a system in place with the same day clinic, so that people can reach out to us directly. We leave appointments for same days so that people don't end up in the emergency room. We have somebody who's on call for pediatrics and adults at night, so that somebody can call in case of an emergency. And so it's really just letting people know that this is their second home, and this is the home that takes care of them as a whole, and that that's important, so that they don't end up in the emergency room unless it's a big emergency.
Oh, sorry, Deborah, do you want to chime in? Or fantastic. So we have a question from
Can I chime in for that one?
Yes, of course, Rose. Please.
So I wanted to say for community of color, it's a matter of building trust because they view hospitals as places where they can trust. So we have to educate. We have to do thorough education to build that trust so that they can go and use the resources. Otherwise, it becomes very difficult. They just think about Tuskegee experiment and all those experiments where they think they've been guinea pigs. So I think education is the key. Going to and meeting the people where they are, educating them, so build trust so that and you can answer a lot of their questions. Even COVID, we see a lot of residents sometimes who are holding back. And even though we've talked about what's in the vaccine, they still think that it might change their DNA. So education is really important. So we are holding monthly residents meeting with the nurse to answer their questions and just build that rapport and trust so that they can feel comfortable. Right now, we have 3 groups. Rush and IIT are holding a brainstorming session with our teenagers who are mostly left out, and they suffer from trauma, they suffer from depression, and they have a lot to offer about devices that they might be able to use. So we are having that brainstorming with them. We're having brainstorming with mothers of small children. They have different dynamics. So we need to hear from them. What would they like to see? And then we are holding a brainstorming session with adults who also have different dynamics. So I think building a relationship and trust is the key.
Let me ask the audience question, because I think we are reaching the end of our conversation almost, but it's quite a good one. What are your thoughts on a space for children in under-resourced communities? What do we need to change with indoor or outdoor space to support their health? We can start with Sheila for this
one. I think I'm going to pass on this because I think someone else may have more insight.
Sure, maybe Paola, because she works with children.
So basically it's providing a safe space. Oh, there's my daughter. Hi. So what I have noticed is, so we did a Comer Sano program, which in Spanish means eat healthy. And we took children for 6 weeks and brought them into the clinic. We would track their weight, and then we would do classes on education and exercise and healthy eating. How do you read a food label? What's the difference between calories now and in the past, and why have people gained more weight? And one of the biggest things that I found was that there isn't a safe space for some of our children to go out into the park, because there are people, I'm right by Humboldt Park. There's been a lot of shootings lately. There's a lot of gang wars. And so parents are terrified to take their children to the park. And if they don't have transportation, you can't go to a nicer park and take them. So I think that a community resource that builds something that is secure. So in the clinic, our staff themselves were feeling scared because somebody ran through our parking lot in the middle of a gang war shooting. And so we reached out to our local community police, and they actually, through a friend, had a security team that are all cops, but do this on the side, and they come in and they moonlight for us, so that our staff and our patients can feel safe coming into the building the nights that we're open till 8 o'clock at night, and somebody can walk them to their car. So I think it's just building something in the community where it's proven that it's gang free, that it's a safe zone, that there will be people there that are going to protect them because they realize how important that exercise and getting out really is.
Abigail, do you want to talk about the design elements of this question?
Sure. I think for children, it's a different dynamic than designing for adults. And when I was at Lurie Children's, and we had a lot of patients who could not do things that normal children could do. And so for us, the importance of building a space for children was to really think about it from the different perspectives that they explore and the things that matter to them. and we talked with a number of patients. We had a really, really active patient and family group that they were an advisory group. These were people who, like, their children had constant care needs. So they would be in and out of the hospital on a regular basis. So they understood the nuances of getting care. They understood a good experience versus a bad experience. Their parents understood when to advocate for the children and so forth. And so we engaged this group to help us design spaces. And one of the things that we came up with was this indoor garden that was actually on our 11th floor. It's a sky garden. If any of you have been to the facility, you'll know what I'm talking about. And it's a large, it's almost 3 stories. It was a glass cubicle that had a small bamboo forest in it with a variety of different colored elements, furniture that was fun and whimsical. And basically what we did was we developed that garden so that patients who were in the hospital, their siblings and so forth, could experience that garden. But then there was a small perch on the floor above where if a patient was immunocompromised and they couldn't be down mixing with the rest of the people in the garden, they were able to come to that little balcony and they were able to experience the light and the air, and they could hear the noise, and they could feel like they were participating in that space. And the landscape architect, who was a woman named Mik-Young Kim, her daughter had experienced being hospitalized. And so we worked a lot on the concepts of being able to address the various different needs of children in this environment. And it was really providing them that environment in a way that they could access it, given what was going on in the rest of the space. And we followed that up with programming throughout the rest of the hospital. And we asked the patients, like, what do you not get to do when you're sick? What are the things you never get a chance to do? And they actually identified the fact that museum access was not something that a lot of these children could do because they were sick. They couldn't go to the museum. So we engaged a lot of the cultural institutions in Chicago and asked them to come to Lurie and do programming for the different floors. And this was a way that the patients could experience a cultural institution, but it was in the way that they could do it where, when their care allowed, they could walk down the halls. It gave them a reason to be distracted. And so we found that for children, really listening to what their needs are and giving them a sense of normal and giving them access to something that they couldn't necessarily get on their own, but bringing it to them was a way that we could close the gap on what they were able to experience in life with their healthcare conditions that normal children just took for granted. So I think when you think about this, you really have to think outside of the box and engage the population that you're trying to design for.
Thank you, Abigail. We have another question from our audience. This is a question to all panelists. As we are listening to this discussion from all around the world, do you believe we can aim for global health equity one day? Are there any specific healthcare systems in any country that you think are successful toward health equity? I want to start with Paola, please.
Do I think one day? I'm hopeful. Do I think we will see that? No. I think we are still trying to do what we can in this country. We see places like Canada that has their universal or government funded insurance, but people can find fault in that as well. The reason that the United States technologically has good healthcare is because of the funding that's put into it and the cost of it, which is excessive. It really, really is. And there are people from other places that will come to the United States, even through Canada, and come to get an MRI in the United States because in their country, it's the same access to everyone. And so therefore you have to wait. And so I think that when there is such differences in finance and strategies of how much you make financially, there are those that are always going to want to pay to get better healthcare. And so that makes it very difficult to make a universal healthcare system.
Good point. Deborah, do you want to add to this question?
I think I agree as well. I'm not sure that we'll see this, but I think, all of us are in this because we have hope. And, you know, and we are making a difference even in a small way. And then I think collectively, you know, that can improve things. So.
Great. We are coming to a close.
I can add a little bit.
Of course, go ahead.
Sorry. I mean, I think that whether or not we're going to see the results in this lifetime, to me, almost doesn't matter. It's just that we have to try. And one of the things that I would love to see more of is taking the data and the cues from the countries that are successfully doing things. And we know these things. I mean, people who have gotten like more comprehensive maternity leave for the father and mother, you know, like all these things, they're little things that people might in the US think are like culturally defined or wasteful that actually really do work. There's reasons why we're like lowest in so many things. So I'm not sure what it's going to take for the US to be a little bit more humble on a policy level, but we as individual practitioners, we have to be part of the solution, or else, you know, there's not going to be any change.
Well, I'm sorry, Rose. I was just going to say also on the other end is that we're seeing our how tied we are to all the entire world. I mean, when you get into a pandemic situation, right? You can't close your borders. You gotta, you know, if we have these underdeveloped countries that don't have access to vaccines, it's going to come back to us eventually. So we really have to be looking at global solutions to some of these big problems that we have.
So I just wanted to add that until we begin thinking about people as not just commodities, but at the center of everything, caring about people, of course, I have hope. I'm not sure that we'll get there, but when we look at countries like Sweden and the Netherlands, they really care about the quality of food that they eat. So people have to be healthy first, and our pharmaceuticals need to begin thinking about lowering the prices. They have to think about people first. So until we get to a point where we value people more than corruption and other things that are going on, we're still in a struggle. But we really need to focus on healthy eating and the environment. And since we have put ourselves as the first leaders of the world, all other countries look at us as leaders. So we have to fix our house first, and then things will fall in place. But there's hope. There's always hope.
Amen to that. Final question for all of you. I'd like to invite each one of you to share with our audience where we can find you online, and if you have anything else that you'd like to plug. But can I start with Abigail, please?
Thank you for this opportunity. You can find me online at LinkedIn. I'm the only person in the United States with my name, so I'm not hard to find. And I would just basically leave the thought with, you know, a little bit on that last question, that really, I think if our objective is to improve the health of the communities that we live in and we serve in as designers and as people who are involved in the healthcare arena, I think we will ultimately help steer the ship in the right direction. I mean, it's really about serving those people that need patient care. It's about helping provide jobs, financial stability through, you know, our supply side and our business aspects of the healthcare side, but it's also exposure and education and giving people a chance for hope. Healthcare it's a profession as much as it is a service. And so if we think about it in the multi-dimensional way that it actually touches our lives, I think we have the best chance of potentially making a meaningful and a measurable change in it. But it needs help. So I think every one of us has a role to play in it. And I agree with Rose. I think there's hope.
Deborah, closing line.
You know, even though, I was asked to speak, I've really learned so much from all of you, and I thank you so much for this opportunity. I can be found on LinkedIn as well, and Synapse House has its own website, synapsehouse.org, as well as Facebook and Instagram. And I hope that you'll follow us and check us out and support our efforts. So thank you so much again.
Rose, where can we find you online, and closing lines, please?
So you can find me on LinkedIn and also at our TCB site, website. And I will close by saying post-pandemic, we've learned 6 very sensitive things that our staff have to go through. And I think the whole country as a whole need to be sensitive to this. One is cultural sensitivity, because cultural racism has been highlighted since the pandemic, and we just need to be really cultural sensitive to each other, you know, and listen to each other. Implicit bias, we also need to educate ourselves. If we don't know, just ask. And racial health and equity is really important. There are some people who have nothing. There are some people who have so much. So how do we support startups for those people who would like to also flourish and thrive? Trauma-informed housing practices, as we continue to build, we need to have this in mind, because a lot of our residents suffer from unaddressed trauma carried over from one generation to the other. And no wonder we see a high rise in violence and youth shooting each other. It's not a coincidence. It's because of structural racism. Mental health 101 training is really important, because the way you address each other or the way you address a resident, even staff, we also get tired. And we also get burnt out. So we need to know how to address each other. And self-care is very important. When you feel burnout, you need to give yourself a break or give your staff a break and let them go and get rejuvenated. And then psychological first aid is really, really important for everybody to get training and certification in that. But there's hope.
Thank you, Rose. Jenny, please.
So I'll start with where you could find, and because I mentor high school girls, I'm on every social media site, mostly just stalking them and making sure they're behaving. But so LinkedIn is appropriate to find me. But I would also add that as we talk about community representation in our projects, as we sort of vision and plan, I'd like to see and challenge the audience in our groups and my company to have better representation of our communities in our companies, and as practitioners and leaders in our companies, in the C-suites and in the boardroom. And so that's the only way I think that we can really comprehensively make sure that we're addressing community needs in a way that's authentic.
Great. Paola, please.
I am on LinkedIn as well, and the clinic has a website which is going to be redone in probably in about a month or two. It's actually really nice. It's the infantwelfaresociety.org. And then, just thank you so much for having us. I'm so happy that I was able to do this, and then just see, such smart and educated women, because I think that in itself says that we've come such a long way, different backgrounds, but it helps because it changes the way that the world sees us and the way that we're able to change the world.
Thank you, Paola. And Sheila, please.
Yes, hi. So I put my contact for my website in the chat. So if anyone's interested, please check me out there. It's got all my contact information. And I wanted to allude to something that Rose just recently said. For all of you on the call who are caregivers and healthcare professionals, thank you so much. I'm just encountering throughout our, the planning and design work I'm doing, the amount of burnout and how exhausted our caregivers and providers are. And, I think we should do everything possible to support them in every way. And as a designer, I'm looking at ways to support them through the design of the facilities that I'm doing. but I think it's something extremely important right now, especially coming out of the pandemic. So for those of you on the call, thank you very much, and any of you out there, thank you also.
Thank you all, Deborah Giesler, Dr. Paola Portela, Dr. Rose Mabwa, Jenny Hunt, Sheila Cahnman, Abigail Brueggeman. Thank you so much. It was great, and thank you for composing this great conversation. Again, for our audience who are AIA members and they forgot to put their AIA number on the registering form, please email it to justinbanda@jbanda@legat.com, your name and your AIA number. Also next week, you will be receiving a post-attendee packet that will include the panelist suggestions for further reading, as well as the ways to get in touch with the panelists. As this is the last session of Think Tank 2021, I also want to thank on behalf of Think Tank team, Justin Banda. He's our director and he works so much for putting all of these panelists together, discussing all of the discussion. And we're just so fortunate, to have such a group behind these conversations. I'm just speechless, to bring all of these professionals together and have these conversations, just a blessing. My pleasure to be with all of you today. Thank you.
Thanks, Sapita. So I do have competition results, and it was very close between two of the entries. But the winner of the Audience Choice Award for the Global Playground was this team comprised of Ross Jackson and Robin Randall, the Exquisite Playground. Ross and Robin wrote a little bit about it. They wrote that playtime is fluid, uninhibited, intuitive, and enjoyable. They wrote that play restores energy and hope, that it's something that we look forward to, that we reward ourselves with, and is the opposite of work. Play is unencumbered, ageless, permission to be silly and unrestrained, a release from worry, a distraction from illness. It can be a shared experience, and it can be a solo experience, sometimes at the same time, both. Playtime offers a smile of anticipation. Just thinking of playing makes us less anxious. Looking forward to play is almost as restorative as active playing. This entry is an architecturalized version of the game Exquisite Corpse, created through play. First, each group member brought several images of projects, real or imagined, to a design charrette. Images contained favorite works of architecture, favorite restaurants, imagined landscapes, and play structures. Group members took turns cutting and pasting architectural and play features to a background image, each move a reaction to the previous. The result is a place, unconstrained from limitations, to hold all these thoughts. A place to find laughter and remember curiosity. A place to be authentically ourselves, unjudged, accepted, and loved. So congratulations to this team, Ross Jackson, Robin Randall. You guys are going to get some Visa gift cards shortly. And then lastly, to follow up on Sapita's point here, Think Tank is a massive effort. And as we kind of wrap up this season of Think Tank, it's important to look back at the scale of some of what we've accomplished. This year's Think Tank season produced almost 700 minutes of recorded content. 385 hours were spent by our team developing content, writing essays, generating program. We've had the fortune to have almost 160 unique attendees across all 4 of our sessions. We have had 21 total speakers representing 3 countries and 12 states. It took us 18 total Legat employees to help out in some way, shape, or form. We offered 12 unique AI learning units that were approved this year. And obviously we have a ton of hosts and people representing our 4 studios in 3 states. Think Tank, originally was conceived in 2014 by Robin Randall, my former professor, professional mentor, work mom. This original event was couched as an internal company activity that didn't have any guests, had about 20 to 30 participants, and was held at a warehouse in Chicago on a Saturday morning. And over the years, Think Tank grew with the support of Robin and others to include external guests, a competition component, workshops, sponsors, partners, both professional and educational, multiple tracks, and a post-event follow-up with attendees. And even over the course of the pandemic, a jump to virtual programming. But through all of this, Think Tank has retained one important primary characteristic, and that is curiosity. Curiosity is admittedly a hard thing to sell. As designers, we kind of start out in these fun, inventive programs, designing crazy conceptual buildings that could never really exist in reality. And as we progress in our education, this system that we live in gradually crushes curiosity out of us in favor of code knowledge, occupancy loads, construction details, and that spark eventually dies out. But the knowledge that replaces curiosity is marketable and makes us hireable, so we let it replace our curiosity. Think Tank is an opportunity for us to rekindle some of that lost spark. Where else do we get the chance to bring together teachers, doctors, developers, academics, urban planners, regional retailers, architects, healthcare workers, all under the same roof? When we ignite these cross-cultural conversations, we create a sense of wonder and possibility that gives us hope for a more collaborative future. We are so fortunate to be able to do this. As we wrap this up, I want to acknowledge a couple of people who were instrumental in making this year a success. I want to offer my sincerest thanks to our 2021 Think Tank team and thank them for their incredible work. That is Ross Jackson, Adam Quigley, Nicholas Woodard, and Sapita Asadi. You guys were the 4 real superheroes this year and did most of the legwork. Thank you also to Zach Campbell for filling in as a host for us at the last minute last month. I also want to acknowledge the marketing and leadership teams for always unquestioningly giving us whatever we ask for, and that is Ted Hogg, Robin Randall, Ann Tranter, Jody Boyce, Anna McDonough, Maria Osterberg, Douglas Aguric. I'm sure there's somebody that we're forgetting here, but lastly, I just also want to thank Legat Architects as a whole for always supporting the Think Tank, even in the years we might not fully have our act together. Think Tank's DNA originates in Legat's mission and values, and so without Legat, there is no Think Tank. So thank you, and we will see you all again next year.